So hi everybody, I'm Hillary Bagshaw. I'm one of the radiation oncologists, obviously. I do mostly genitourinary cancers, but I also do brachytherapy, which is part of, treating GYN malignancies. And so hopefully you can all see the slides here. I'm just gonna go ahead and go through them. Feel free to interrupt me, chime in, chat questions. But you can also just shout questions out if you guys have any. And I was just looking at your calendar, so I understand today you had a radiation biology lecture, it looks like, and a kind of intro to radiation oncology. So I try to keep it, pretty straightforward. But there may be some concepts that you may learn more about as you go through the rotation here. So again, if you have questions, just shout them out. Just so that I know how many people know much about radiation, or I guess who's had exposure to radiation, maybe just you can raise your hand since I can see you guys. 2 of you, 3 of you guys. Okay, great. So again, if you have no idea what I'm talking about, just interrupt me and I'm happy to explain things. I didn't want to get too granular, but also didn't want it to be too boring. So how about GYN cancers? Anyone had exposure to GYN? 1. Okay. All right. 2. All right. So maybe a little new, but hopefully you guys will learn something. All right. So first question, maybe this is just shout it out. Can you guys just name, or you can type it, I guess. Anyone knows some gynecologic cancers? Like, what are we going to talk about? Cervical, ovarian, yep. Endometrial, uterine, yep. Choreo, very rare, yes. Vulvar, good. Awesome. So vaginal, yep. So basically all of the female organs, but yeah, so endometrial is also AKA uterine, ovarian, that's a big one. Vaginal or vulvar, these are the ones I'm going to talk about today. There's some other really rare ones like fallopian tube cancer and stuff like that, but I'm not going to talk about those. So, okay, anatomy. Shout it out or in the chat. Anyone tell me what 1 is? Does anyone know what this anatomy is? What's this thing? Uterus, yep. How about, what's 2? What's this?
Cervix.
Cervix, exactly. And how about 3? Vagina.
Vaginal canal.
Yep, vaginal canal, exactly. Good, and let's see. Do I have this in the right place? Oh yeah, 4, what's 4? Labia, yes, and another word for that is vulva, correct? And 5. Ovary, exactly. Perfect. So those are, that's just kind of overview the areas we're mostly going to be talking about today. Obviously in the pelvis, there's a lot of other cancers you can get in the pelvis, but in the female pelvis is what we're going to be talking about. So to just give you a little overview, let's see, you can see here, this is from American Cancer Society this year. Obviously, breast, lung, colon cancer are more common, but the fourth most common type of female cancer other than a skin cancer is actually uterine or endometrial cancer. But you can see that, and then you can see the incidence I've listed here of the other cancers. So that, after leukemia, you've got ovarian cancer. Cervical cancer actually is, not super common, at least in the US. And vaginal and vulvar cancer are even less common. But you can see over here, while ovarian is, doesn't even make this top, whatever this is, 10 list or whatever, it's, accounts for, it's the 5th most common leading cause of cancer death in women. So it's a very aggressive cancer. Uterine cancer actually is also quite a high cause of mortality for women. And you can see just looking over here, so cervical cancer, 14,000 cases, maybe 4,000 deaths. And vaginal and vulvar cancer, because they're so rare, they actually, their percentage death rate is actually quite high. So just to keep in mind kind of how common these things are when we're talking about them. Okay, so I just wanted to point out that who manages GYN malignancies? So as you probably learned from Jacob's lecture, usually it's kind of like 3 people: radiation oncologist, medical oncologist, and surgeon. In most academic centers, GYN cancers are handled by the gynecologic oncologist, which you may or may not know. You do an OB-GYN residency and then you do a fellowship in gynecologic oncology. And they actually manage both the surgery and the chemotherapy. So it's kind of unique in that they do both of those things. And that's very rare for the US. Usually you don't have the surgeon managing chemotherapy. And then you have your radiation oncologist, where, as you may or may not know, you do a general internship and then you do radiation oncology residency. And then you can specialize in GYN malignancies, or you can do everything. So that's kind of the team. So, the other question, just for context for you guys, when do we use radiation in these cancers? So mostly we're treating cervical and endometrial cancer patients. Then vulvar and vaginal. I mean, these are just so rare, as we talked about, so it doesn't come up that much. And then the odds that you use radiation, more in vulvar. Anyway, we'll talk about it. But we don't see them that much, so we don't use it that much. And in ovarian cancer, we used to use radiation quite a bit, but we actually don't really use it much, anymore, only for really metastatic disease. So when we're learning about GYN cancers for radiation, we're really talking mostly about these two, and then a smattering of these, and then you got some super rare runs as well. Okay, this may be like already gone over, but just to give you a little intro to radiation. So we've got external beam radiation that usually is photon radiation, and Jacob probably touched on this today. There's different buzzwords that we use, like 3D conformal radiation, which is a little bit older technique, and then more conformal techniques called IMRT or VMAT, volumetric arc therapy. There's also internal radiation called brachytherapy, and we use this a lot in GYN cancers. And those are different sources, and I'll talk a little bit about that. There's other types of radiation, like intraoperative, stereotactic, and these are some acronyms you may see, and CyberKnife, which we don't really use that much for GYN cancers, occasionally for metastatic sites. Any questions about these types of radiation? No. Okay. All right. So we're going to start with I'm just going to kind of run through each one, give you a little background of the type of cancer, and then kind of like how we use radiation for each one. And it's definitely like a broad strokes overview, but I just wanted to give you guys kind of like an intro to GYN cancers. Okay, so here's the cervix we're talking about, at the end of the uterus. And there's different kind of regions of the cervix and anatomy of the cervix itself. As we talked about in the US, we talked about the numbers, but actually worldwide, it's quite common. So there, oh, this is wrong, sorry, that can't be more than this, but worldwide, there's about 500,000 new cases per year, and there's a high incidence, high death rate as well, and you can see kind of the distribution. Most of the we could say locally advanced, meaning basically what it sounds like involving not just the cervix, but other organs in the pelvis or lymph nodes, things like that. Most of these cases occur in low and middle income countries, and there's a high death rate associated with that. It has been the second most common cancer in the developing world and the leading cause of cancer mortality in developing countries. So it's a huge problem worldwide. So I think I had some questions. Again, you can use the chat or shout them out. Does anyone know what type of cervical cancer is most common? If you don't know, if you know the type of cell.
Squamous cell?
What is it?
Squamous cell carcinoma?
Squamous cell, exactly. So that's because that's the most common, cell of the cervix. And you can also get other histologies like adenocarcinoma, clear cell, things like that. Those are more rare, but you can certainly see those. Anyone know what virus is associated with a risk of cervical cancer? HPV. Yep. So HPV, we usually say 16 and 18. There's a lot of different strains of HPV, however, and those can be associated with the risk of squamous cell carcinoma of the cervix. Now, this is specifically, I should say, squamous cell, so adeno, clear cell, et cetera, is not associated with this virus. Anyone tell me what screenings prevent cervical cancer?
Pap smear.
Pap smear, exactly. So you do that, as you guys have probably learned, with a speculum exam, looking at the cervix. You take a brush and take a pap smear, and they look for atypical cells. There's different recommendations, not going to go into that as far as when you do it, how frequently, what age, etc. But the pap smear has been, attributed to certainly decreased or cause of death of cervical cancer, just because we're picking it up so early, like when it's even a pre-cancer. Okay. Oh, I wrote 70%. There's studies decrease mortality from cervix cancer by 70%. So you can imagine if you don't have access to screening, that's a huge barrier in diagnosing and preventing the disease. Does anyone know what interventions can help prevent HPV infection?
Vaccination.
Yeah, exactly. So Gardasil was introduced in 2006, and I believe now recommended for both men and women. It used to be just for females, and then they realized, well, no, it's sexually transmitted, so we need to give it to everybody. So again, this is great, but you also have to have access to the vaccine, right? So, okay, great. So what are some risk factors? Like we said, mostly HPV, because the most common cause or histology is squamous cell carcinoma. Other risk factors listed here: smoking, parity, early age of sexual activity, which kind of goes hand in hand with just increased risk of contracting the virus if you're not vaccinated, and contracting HPV, immunosuppression, and DES exposure in utero has been linked to adenocarcinoma of the cervix. So how do people present? Usually now, if you can get one, it's an abnormal pap smear. So again, that means you have to have access to get a pap smear and get a test, etc. If people have locally advanced disease, they don't pick it up right away. They could present with heavier bleeding called menorrhagia or metorrhagia, meaning between menses bleeding, abnormal vaginal bleeding after sex, for example, pain in the vagina, discharge, or pain with urination. Okay, so any of those things, you have to kind of get looked at. Staging is something that we call FIGO staging, which is actually a surgical staging system. And so here's the 2018. There's been a couple changes as far as how they kind of stage things, because while it is a surgical staging, now we have PET scan, we have MRI, those kind of things. We can pick up nodes prior to operations. And so you kind of listed here, but basically you can see, if you're a 1, you kind of have just microscopic disease of the cervix, probably picked up on a pap smear. Same with 1B disease. If you have, this is kind of what we call locally advanced or beyond the cervix or into the vagina. And then if you have it in the distal vagina or pelvic sidewall, that's, kind of very advanced disease or in lymph nodes. And so I kind of skipped ahead, but surgery is the mainstay of therapy for these, smaller lesions, because you think about the cervix, sometimes if it's a precancerous lesion, you just got away with a cone or a leap, what it's called, where they just kind of take that part off. If you actually have invasive squamous cell carcinoma of the cervix, You can undergo a hysterectomy, and actually sometimes they do what's called a trachelectomy, which is where they just take the cervix, but it's a very kind of selection. You have to be highly selective for that procedure. And sometimes we add postoperative radiation or postoperative chemoradiation for these patients who have certain high-risk features, but not all the patients. Okay, so then when do we use radiation? Usually for large lesions, about 4 centimeters or above, and kind of more advanced disease, so vaginal involvement. Parametrial involvement is the tissue on the sides of the cervix. And then when we get into the vagina sidewall, or disease causing hydronephrosis, because it's so bulky, it's kind of compressing your or those that have pelvic nodes or other organ involvement, we're going to be using chemoradiation, a combination of chemotherapy and radiation, which includes external beam and brachytherapy treatments. And you can get surgery, you could get surgery for these, but you're probably not going to get it all out. You're probably going to need post-op radiation. It's going to be more morbid because if it involves the distal vagina or rectum or something, you're going to need like an exenteration. So it really doesn't make sense to do surgery for these patients who have such locally advanced disease. These are just some pictures to try to show you kind of what we're talking about. So like a 1B2 lesion, is confined to the cervix, but it's smaller than 4 centimeters. Now called 1B3 lesion is greater than 4 centimeters, but still confined to the cervix. If you have a 2A disease, you have some vaginal involvement, but no parametrial involvement. If you have 2B, this is like the mainstay of where we start using radiation, is you have parametrial involvement. So like this fat kind of just adjacent to the cervix. And then 3A is like all this lower vaginal involvement. 3B is extending to the pelvic sidewall, and then you have 3C disease involving lymph nodes. Okay, so definitive chemoradiation, what does that involve? Typically, concurrent chemotherapy, including cisplatin or a platinum chemotherapy if they can't get cis. And then we give radiation concurrently to the pelvis and brachytherapy, which I'll talk about a little more detail. So why do we treat the pelvis? We say we treat the primary cancer and then the lymph nodes at risk, even if they don't have lymph nodes involved. So the most common places for cervical cancer patients to have lymph node involvement is the iliac vessels, presacral disease. Very uncommon to have inguinal disease, but you can see like parametrial disease here, which was that area we were talking about. So we treat kind of this whole region of the pelvis. So with external beam radiation, as you may have learned from Jacob's intro talk, there's different types. So there's 3D conformal, which is still a conformal treatment, but less conformal than IMRT or rapid arc, or also called VMAT. And here are some examples of 3D conformal fields. So this is a plain X-ray. Can anyone tell me what orientation this X-ray is on the left? You guys learned that at all? I saw someone mouthing it. A lateral, also called technically sagittal. I think someone mouthed it. Yep. So a sagittal, and then how about this one? Can someone tell me what's this orientation? Coronal, frontal. So technically in the, it would be coronal if you were talking about I guess technically, if you're talking about a CT scan, this would be sagittal, this would be coronal, that's right. If you're talking about an X-ray, it's correct to say, as the first person pointed out, this is a lateral, this is an AP or a PA field. That's kind of a nuance, but so you can do this kind of 3D conformal radiation, and as a resident, this is the kind of thing you learn about, like, okay, if I'm doing 3D conformal, where's the top of my field? Okay, it's at L5S1 interspace. Where's the bottom of my field? Okay, it's at the bottom of the obturator foramen. Laterally, I come 2 centimeters off the pelvic brim, and we make this kind of stop sign thing, and then you know, we do the same thing from the PA. So those are some of the things you learn because you have to know, sometimes you have to know kind of like the older school way of doing it or the 3D way of doing it, which requires you to memorize this anatomy. Now we can use CT scans, and that allows us to do IMRT treatments. So IMRT treatments, we use a CT scan, well, with all of them actually, but we use a CT scan to basically contour out what we want to treat, the cervix tumor, the lymph nodes, and you can see these, what we call contours, you know, projected. Here's a axial view of a CT scan. And these kind of, this red line is like what we call the PTV, or the planning target volume, that includes the lymph nodes as well as the primary cancer in the middle that you're treating. And so you always contour those out, but you can see that here's again an example of an external 3D plan with a lateral and an APPA field setup. And to show you the dose distribution over here in red, you can see that, you know, the 100%, let's say, is kind of this big box. So it is encompassing our PTV in the red. But when we turn on, let's say, maybe this is 5% or something, you can see this dose splaying out because you're bringing in radiation from the front and from the sides and from the back, okay? So people, then we have this new technique called IMRT or VMAT. We do the same contour here. However, you can see in both of these projections that instead of bringing the radiation just from 4 areas, we're bringing the radiation in from, you know, many, many different angles, which is optimized by the computer program to basically give you something like this. So instead of 100% being this big box, 100% is kind of conforming around just what we want to treat. So we're avoiding the bladder, we're avoiding the rectum, and some of the small bowel a little bit better. Okay, so so you can use either of these techniques in pelvis radiation. Does anyone have questions about this part? No. Okay. All right. So then, what else? We said brachytherapy is a mainstay. If you're doing definitive chemorads for cervical cancer, you should use brachytherapy. We can't just get away with external beam radiation. It doesn't do as well. And what brachytherapy allows us to do is basically place internal radiation right up against the cervix cancer. So for example, here's, you know, a lateral view. We're calling this the GTV, or the gross tumor volume, which is in the cervix. And this is called a tandem, which is this, tandem and ovoids is a device we use to first place that then allows us to insert the radiation into this device. And so the tandem is this central portion, and you can see it actually goes up into the uterus. You can see here's a CT scan, sagittal view, and here's the uterus, and here's the tandem into the uterus. And then we have what we call ovoids, which are just, you know, 2 pieces of plastic essentially that allow us to, again, put the radiation source up into this piece and into this piece, which go just flanking the cervix. So you can see here, this is an ovoid and this is an ovoid. Can't really see them in this view, but this is the coronal view. You can see an ovoid here and an ovoid here. And again, if you can imagine a tumor right here, this just allows us to put a piece of radiation right up against the cervix tumor. So it's much more effective than the external beam treatment for these squamous cell carcinomas, which respond very quickly to radiation. So I think I have it here. Okay, so what happens is, you know, the patient is put under some kind of sedation, whether it be general, spinal, whatnot, and we insert this applicator, so the tandem, into the uterus, and then the ovoids just up against the cervix. We basically stabilize it in place, and you can see a couple pictures of it here. And then what we do is we hook up a radiation source, which is in this device called an afterloader, through these catheters up to each one of these 3, the tandem and the 2 ovoids. And then the little radiation source comes out and in to each of these channels and delivers radiation over about 5 minutes. So Alyssa asks, what are the conventional doses used in EBRT and BrachyBoost? So radiation in external beam, typically you give 45 gray to the pelvis via, oh, how do I go back? Oops. 45 gray via external beam to the whole pelvis, either 3D or IMRT. And then you do typically 5 fractions, so the conversion is a little bit different. It depends on how you're doing it, but essentially to get what we call like a equivalent dose of like 85-ish gray or something like that. So you're doing some calculations, depending on how many fractions of the brachytherapy you're doing and how many fractions of the external beam you're doing to get to like a certain equivalent dose. And there are some calculators you can use and things like that. So the external beam tends to be about 5 weeks of once-a-day radiation while they're getting weekly chemotherapy. And the internal radiation or brachytherapy tends to be about 3 to 5 fractions spaced every few days apart or once a week apart, depending what you're doing. And you usually do that on the back end because as the tumor is treated with the chemo and the external beam, it shrinks. So then when you come in with the brachytherapy, you have less to treat, basically. Any questions about this? Oh yeah, Ellen has put in here what Beth does, who's the main GYN doctor.
Sorry, I have another question. Is the patient sedated during the brachy procedure?
So it depends. Here, I think Beth does all like conscious sedation for the insertion of the tandem and ovoids. And then once it's in, they actually are okay. So then you wake them up because you have to do a couple steps before you actually deliver the brachytherapy treatment before you hook it up to this. So you insert the device, you wake them up, you actually take a CT scan, you do some planning calculations to get you to this kind of plan. And this is, let's see, do I have another? I think I have it in another part, but basically how you get this is by calculating, okay, I want the source to sit in the ovoid for 3 seconds. Okay, or no, I want it to sit, there's more disease on the right side. I'm going to have it sit over here for 5 seconds. And then in the tandem, there's different dwell positions along the tandem it can sit. So you can kind of see in this sagittal view, these little green boxes and this purple box. These are different positions where the source can dwell, we call it. And so it could sit here for 1 second and then move back to here for 2 seconds and then back to here for 3 seconds. So you work on this plan, it takes you maybe 30 minutes or something like that. The patient just is hanging out with this device in. And then you bring them to the treatment room, you hook them up to this afterloader, and then the treatment is delivered. And then that takes maybe 4 minutes or something like that. And then once the treatment is delivered, you unhook these catheters, you take the whole implant out of the patient's body, and then they go home. So it's uncomfortable when you take it out. If you have them sedated, obviously it's more comfortable. Other places, don't sedate them fully. And yeah, good question. This is all outpatient, so the patient just comes in and goes home the same day. And because this is something called high dose rate brachytherapy, where the source is always kept in this machine called the afterloader. So there's only exposure is when the source is out in the device. So as the staff, we're not in the room when the source is in the patient. We leave the room, we monitor them with video, and then we come back in and remove the device, which is not radioactive because the source has now gone back into the afterloader. Okay. There's older brachytherapy techniques for GYN cancers where you actually leave a hot source in a device in a patient for multiple days. And we've gotten away from that because, as you can imagine, these people had to then be in the hospital with certain restrictions, staff was exposed to them, things like that. So it's a huge headache. So most people just use high dose right now. Okay. So, and this, I would say, for radiation oncologists doing brachytherapy for GYN cancers, you know, you're mostly doing these tandem and ovoids for GYN cancers. Like, it's very, very common for us. As a resident, you do a lot of them. You know, we always have someone on treatment getting this type of procedure done. So it's pretty like a mainstay of our training. So, and I told you a little bit before, like, these patients really should get brachytherapy if they have locally advanced disease, which is kind of that box I was showing where we use chemorads. And it's because a couple things. Well, first of all, chemorads has been shown in randomized trials to be better than radiation alone. And external beam and brachytherapy has been shown to be better than external beam alone. You just don't get the same response with external beam radiation. And then I'll answer this question about the shielding in a second. So you can see, this is from actually a 2013 paper where they looked, I think it's SEER, but they looked at patients that had brachytherapy for treatment of their locally advanced cervix cancer and patients who did not. And they actually don't do as well. They don't survive. Their overall survival is significantly worse if they don't get brachytherapy. So it's really, really important that radiation oncologists are trained in brachytherapy and that they're comfortable giving it, and that if patients have locally advanced cervix cancer, that they actually come see a radiation oncologist for brachytherapy specifically. And you can see that actually, you know, survival's pretty good, but so 2B is the patients with parametrial involvement. So once it kind of spreads outside the sides of the cervix, you can see that survival kind of like drops off quite a bit. So that, you know, these patients, yeah, they need really aggressive treatment. So if we don't give them brachytherapy, we're even doing more of a detriment to these patients. Okay, so the question was, how is a delivery catheter shielded? Is this unit single use or per patient, or is it reuse? Good question. So this is called the afterloader. I actually don't know what the shielding is. I presume it's lead mixed with some other things. So the source is kind of in a unit in this afterloader, and interestingly, this is actually locked to the room. So it's very interesting in radiation oncology. If this were to be unlocked and we didn't notify someone about it, or we thought the source was stolen, you can when I was a resident, actually, where I worked, we had a SWAT team show up because something happened with the source, and it wasn't like, you know, we didn't alert someone we were moving it to another room or whatever. So it's like very, very highly regulated, because this is like very, very dangerous if it was to get in the wrong hands, obviously. So I don't know exactly what the shielding is, but it's a lot of shielding, because I can stand right next to this and not be exposed to radiation. But if it was in my hand, you know, that'd be a huge, huge problem, obviously. So in here, it's a little piece of iridium, which is what we have. It's attached to a wire that's motorized. And these catheters are reused per patient, but this catheter hooks up to the end of the ovoid, for example, and the source runs on its wire via the motor through the catheter into the ovoid, sits in here, and then runs back into the afterloader, then back out into the tandem, etc. Now, the tandem and ovoids are reused and sterilized between each procedure, just like any surgical instrument. And the catheters are reused, but they are also washed or sterilized. So the source itself never touches like the inside of a patient, or, you know, gets any fluid on it or anything like that. But these devices are reused. Okay. Okay, any more cervix cancer questions? Let's see. I'm going very slowly, so I'll try to just get through these couple, but other questions about cervical? No? Okay. So endometrial cancer, also called uterine cancer, is the kind of the next more common GYN cancer that we treat in radiation oncology. And there's a couple layers of the uterus, endometrium and myometrium. And let's see, true or false, endometrial cancer is the most common GYN malignancy in the United States. United States, not globally. True. Yeah, true. The 3% lifetime risk. What is the most common histology of an endometrial cancer? Does anybody know? Adeno, correct. So type 1, also called type 1 or estrogen related. And does anyone know a risk factor for endometrial cancer? Thinking about estrogen exposure, correct? And a lot of the time we think of obesity because of high estrogen exposure. Okay, so risk factors, listed them here. We kind of talked about it. I'm going to kind of skip through them just because the interest of time. So how did these people present? Usually postmenopausal bleeding, and usually it's around age 60 that we see endometrial cancer patients. If they have more advanced disease, they can also have pelvic pain or bowel and bladder symptoms. So how are these patients treated? Surgery is really the mainstay of treatment for endometrial cancer. You know, they get their biopsy, they get their workup. I didn't go through all that in the interest of time with you guys, but usually it's a total hysterectomy and a bilateral salpingo-oophorectomy. They get peritoneal cytology and a mental biopsy depending on their histology. So there's different types of hysterectomies, which I'm not going to get into, but essentially more or less kind of aggressive or taking out more or less of the parametria, vagina, cervix, etc. And you can see that here. So when do we use radiation then? It's always adjuvantly. I mean, there's rare cases where we actually do treat endometrial cancer patients definitively when they cannot get surgery. However, that's very few and far between, so I'm not going to touch on that. So typically there's some combination of chemotherapy, radiation, with external beam brachytherapy or both. And sometimes a sandwich regimen where you do like chemo, radiation, and then chemo or something like that. So for staging, it's again FIGO because it's surgically staged. It depends on, you know, the kind of invasion into the myometrium and then also into the serocyte, nexa, et cetera, parametria and nodal involvement, very similar to cervical cancer. So you can see 1A is basically, you know, less than 50% myometrium, 1B greater. And then as, you get more advanced, you can have cervical involvement, vaginal involvement, parametrial involvement, nodes, etc. This is very confusing. I'm not putting this up to like have you read this, but basically you can see for a stage 1 patient, which is a patient that only has disease confined to their myometrium, depending on the kind of grade, etc., at the time of surgery, you basically always use some kind of radiation. So we're seeing a lot of these patients, and it's very common for us to treat endometrial cancer patients. So sometimes you just use brachy, sometimes you use brachy, radiation, external beam, and chemotherapy. Okay, so we've already kind of touched on this, but the radiation for endometrial cancer is very similar to cervix, although it's just in the post-op setting. And usually then in the post-operative setting, we're using IMRT because it's been shown to minimize side effects when you know, the uterus is no longer here. So like we talked about before, it's many little beams coming in from many different angles to treat the pelvic lymph nodes, as well as kind of the potential space where the uterus used to be. Occasionally, we also use brachytherapy, a different type of brachytherapy than we just talked about with cervical cancer, but it's very similar. So obviously there's no uterus anymore, so what do we treat? We treat basically something that we call the vaginal cuff, which is where, you know, they took the uterus and the cervix out, they sew together the vagina at the kind of top, and that's called the vaginal cuff. And certain patients have risk factors to have recurrence at the vaginal cuff. And those patients, I'm not going to go into that you would learn as a resident of radiation oncology, but the best way to deliver radiation just to this rim of tissue is via a vaginal cylinder, which I tell patients is kind of just like a very large tampon that is inserted into their vagina. And the size, you can see these are different cylinder sizes, and you can kind of put multiple together to be different lengths depending on the patient's anatomy and how much of the cuff you want to treat. This just depends on their anatomy. So you create this cylinder. It also has a hookup here for the catheter, just like we talked about with the cervix patients. And then you insert it into their vagina, and you take a CT scan of them with this in place, and then you plan out a radiation treatment, just like we were talking about. You can see all these little squares is saying, okay, I want the radiation source, again, to sit here, 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 and here. And then you deliver it, very similar to what we just discussed. Now, these patients, again, it is outpatient. You typically do not sedate them because it's less painful than putting in a tandem into the uterus. Not to say it's not uncomfortable, but typically you may give them a little Vicodin or something, or an anxiolytic. You insert this, you take a CT scan, you plan it, you deliver the treatment, which again is like 2 minutes. You pull it out, and then they're on their way. So this is, I may skip through some of these in the interest of time, but basically, as we were talking about, here's the cylinder. You can have the source sit at any of these little spots, and you can calculate the dose of radiation that will go to a certain depth, around them. And in brachytherapy, we usually talk about ability to deliver dose within 5 millimeters of the source. So it's very nice because it's very conformal, and it doesn't give a lot of radiation to other things like the bowel and the bladder and stuff like that. Here's an example of a plan with a dose on it. So here's the cylinder in the middle. The 100% dose is this kind of thick yellow line. So you can see, well, I'll tell you, this is 5 millimeters from the surface of the cylinder that we're giving 100% of the radiation dose. And then we have, dose fall off from here, but this is really not that much radiation. Any questions about that? All right, and these patients actually do pretty well, better than cervical cancer patients, but as we discussed, it is one of the top causes of cancer death in women. So, we do see a lot of these patients. Okay, so we have about 15 minutes just to keep myself on time here. A couple more things to talk about. So vulvar cancer, as we talked about, is the labia. There's obviously different anatomic parts of the labia. It is the 4th most common GYN malignancy, not to say this is the 4th most common cancer in women, but of GYN cancers, it's the 4th most common, accounting for about 5% of all GYN cancers. And we said it's not very common, but it does cause a lot of death. Lifetime risk is about 0.3%, as compared to endometrial cancer. It gives you a sense of kind of how common it is. Risk factors are also HPV, because this tends to be squamous cell, 85% squamous cell. So similar to cervical cancer, same kind of lining. And other risk factors can be Paget's disease, vulvar intraepithelial neoplasia, and lichen sclerosis. So kind of any like inflammation of these cells can lead to malignancy. Okay, based on what we've talked about, how do you think this cancer is treated? I don't really expect you guys to know, just like what we've just talked about. What do you guys think? Guesses? No? Surgically? External beam? Yes, so typically both. So just like the other types of GYN cancers, it kind of depends on the surgical features. Then you usually use postoperative radiation. Sometimes you're going to use it up front. I'll skip through the staging, but again, it just depends on kind of depth of invasion, or invasion with other structures. There's also nodal staging that's important that you get from the surgical treatment. So first of all, typically if they can get it, they get a surgery, also called a radical vulvectomy, and a nodal evaluation. And then you use that to stage them with a FIGO staging and determine if they need radiation or not. And that's based on risk features, which we've kind of listed here. But there's different indications to radiate postoperatively the vulva and radiate the nodes, basically. And so those just depend on these different surgical features. And those are things you learn as a resident, when to do it, when not to do it. And radiation is very similar to what you guys we've just talked about, is external beam radiation, typically with IMRT. And I'm just going to show you, for historical interest's sake, or I find it interesting, the different fields that were used for vulvar radiation a long time ago compared to now. So this is a schematic that's showing you, kind of in the pink is what you outline as a nodal PTV, like what you want to treat with radiation. So it's the iliac nodes coming down, and then actually the inguinal nodes as well, because the vulva drains there. You're also treating, if you're treating the primary postoperative site, you're treating the vulvectomy kind of operative bed as well. So you can see there's a lot of bowel in the way, the rectum's in the way, the bladder's in the way. And we used to use 3D conformal radiation, which basically, this is trying to show you do a big AP field, which is basically your whole pelvis. These are the femurs. So you're basically just treating through and through from the front, a slightly skinnier posterior field. And then you used electron therapy, which is a way to deliver superficial radiation dose to treat the inguinal lymph nodes in this area. Okay, so it's a really big radiation field. And this is another schematic of it. So this is looking at an AP field. So you can see, like, you're treating the whole femurs, basically, all the bones of the pelvis. Your rectum's in here somewhere, your bladder's in here somewhere, your bowel's in here somewhere. So the nice thing about IMRT or VMAT is, as we showed previously, you can actually really just treat the nodal basins. You can avoid the bowel, the rectum, etc., and minimize a lot of toxicity for these patients. So typically, okay, here's some questions. Are there any factors a patient may have that would preclude radiation, like hardware implants, genetic factors? Those are really good questions. So you can imagine if someone had a bilateral hip implant, you're not going to be able to see anything on CT scans. That actually is a big problem for planning radiation. You'll need an MRI. It also affects the dose of radiation and how it is actually delivered to the body. So that's one thing that makes it challenging. Not a contraindication, but difficult. If they have inflammatory bowel disease like Crohn's or ulcerative colitis, that's thought to be a relative contraindication to radiation due to risk to their bowel symptoms. And then there are other things, as Alyssa, sorry, I don't know if I'm saying your name right, Alyssa said, like ataxia, telangiectasia, other things like P53 mutations, and other hereditary, usually P53, other hereditary genetic syndromes can make you at high risk of developing a second cancer. And as Alan pointed out, they're mostly relative, but you do want to think about all of those things when you're thinking about radiation. Okay, vaginal cancer. These are quick because it's just not that common. So obviously we know that anatomy. It's very rare, 2 to 3% of all GYN cancers, again, mostly squamous cell, just like we've talked about. And you can have other really rare histologies like melanoma, rhabdos, or small cell. These are super uncommon. So interestingly, tumors of the vagina are basically a diagnosis of exclusion in a way. So if you have a vaginal cancer that also involves the cervix or also involves the uterus or the vulva or something else, it's really not a vaginal cancer. Like we talked about, you can have a cervical cancer involving the vagina, and that's a stage X cervical cancer. So a true vaginal cancer is only arising and contained basically to the vagina. Squamous is the most common, like we said. So what are risk factors? Anyone guess? I don't know. HPV, okay. Yes. Squamous cell cancer. Smoking is also a big one. And basically early intercourse, HPV, and sexual kind of exposure, I would say. Inflammation is another one. So some patients can have like that lichen sclerosis we're talking about with the vulva, that can also predispose you to a vaginal cancer. Okay. And staging, I'll skip through, but again, we talked about it's really a cancer of the vagina, not involving cervix or vulva, and you can have obviously paravaginal tissue involvement and nodal involvement. So here's just an example of a patient I treated actually as a resident. This is a PET scan, a coronal PET scan. She basically had full vaginal involvement, and you can't really see here, but she had like her entire vagina involved with tumor, which was like growing into her urethra here. This is the bladder, here's the vagina. And so she had a really nasty disease. So you can have something really, really terrible like this, or you can just have a really, really small lesion in the true vagina itself. And surgery is typically quite morbid. So you can imagine a vaginectomy or a vulvovaginectomy is like a huge operation. You may be left with a stoma, or maybe you need an exenteration of your pelvis. So like this patient, for example, if we offered her surgery, this would involve an exent. So taking out her bladder, urethra, vagina, probably, you know, her rectum, which would leave her with a bag to pee and a bag, you know, to have bowels. And a lot of patients understandably kind of don't want that. So that's pretty morbid. If you have a really small tumor that just can be excised by the surgeon, that's kind of a different story. But if it's more advanced, typically we use radiation again, or chemoradiation, and that depends on the size and stage, etc. And again, just to show you, typically with vaginal cancer, we're going to do a combination. This is getting probably repetitive, of external beam radiation with IMRT and brachytherapy, a different kind of brachytherapy than we've talked about, so I'll focus on that. This is just some pictures of, you know, IMRT, you know, carving out the bladder and rectum from getting radiation dose. Here's an older field picture of external beam radiation with 3D conformal fields, where you can see that, you know, you're just getting a lot more radiation to the bowel, bladder, and the bones of the pelvis. So vaginal cancer brachytherapy is typically, when we do it, we use something called interstitial brachytherapy. We can use this for cervical cancer and endometrial cancer recurrences if necessary, but it's not as common. So because of the anatomy of the vagina, we typically have to use an interstitial implant. And that involves, sorry for the graphic photos, but it involves a kind of obturator in the center. We call it just kind of like a cylinder like we talked about for endometrial cancer. But then on the sides, implanting what we call interstitial needles, meaning just needles going into the interstitial space that are secured in place either by sewing them to the skin or by affixing them to an applicator, that then we can utilize those needles. For example, let's say we're looking at this, the central cylinder, you can put, you know, hook up that radiation source to any of these dwell positions, as well as into these interstitial catheters, which allows us to bring the radiation dose not just in a symmetric circle, but to these kind of odd locations. And so, for example, if you have a vaginal lesion on the one side, you can just put most of the needles over here and put the source over here, and you don't have to treat the whole vagina. You're going to treat, you know, just the one side. Here's another example of interstitial brachy. It's a little more graphic, but you can see that you have a central dwell position, and then you have all these needles around, and you can really shape the dose in a way that is effective for you. There's other devices which I won't get into, but again, this just allows us to bring the dose so that it's asymmetric around the patient as opposed to just, you know, one kind of circle in the middle. And these patients do okay with early stage, but not so good with late stage cancers. So in the interest of time, basically for ovarian cancer, we treat palliatively for metastatic lesions to the brain, bone, pelvis,